I would now request Dr. Ravul Jindal to emphasize on CDT.
Good afternoon, everybody. So I'm going to talk about catheter-directed thrombolysis. So it's a very straightforward thing. What that means is, if you get a clot in your deep veins, how do we take them out? Or how do we make the veins clear? So most of the DVTs, we treat them with anticoagulations. So if you don't want to do anything, have the patients on full proper anticoagulations and a compression, most of your patients will do well. But if you want to do an active intervention, especially in like pulmonary embolisms, in DVT, then you need to be very careful and listen to this lecture. So we know DVT is a blood clot in the deep veins in the leg. And it has got two major drawbacks. One, from the leg, it can go to the lungs and cause pulmonary embolism. Second is, the clots in the legs can destroy the vein walls and cause you a CVI, chronic venous insufficiency, or what we call as post-thrombotic syndrome later on in your life. So we need to treat both of them. So this is very important. So catheter-directed thrombolysis, you have to understand, does not protect you from pulmonary embolism, because that you can do only with anticoagulation. So CTT is mainly, we think, that in long term, it will protect you from post-thrombotic syndrome. So there are some studies which shows that it does, and in some studies it show it does not. Okay? So at present we don't have the clear picture about it, but we have been doing CTT from like 15 years now, and we think it really makes a difference if you select the patients well. So this is the picture which we don't want in the patients with DVT, and this is very common. Okay, so if you will have a lot of patients with DVT in your clinic, so at 8 to 10 years, you will get patients like this. And if you treat them properly, patients will not get this. Post-thrombotic syndrome now, what we are talking about, it happens in 20 to 50% of the patients. And we know there are a particular group of patients where it happens. If you're obese, if you are male, if you get a lot of clots in the iliac veins, IVC, if you get the clots in all these veins along with a long saphenous, short saphenous vein, and in some patients we don't know why it happens. So that's why the only thing which protects is a good anticoagulation, and also we think a CDT. Now, acute iliofemoral means once the iliac veins are involved, then it becomes more useful to think about CDT. So if you have an isolated popliteal vein, thrombus, calf vein thrombus, then doing a CDT may not be really useful. So I really don't do it, because clinically also the leg swelling is mild. Most of the patients get away with medical treatment. You don't want to use so much resources and money and take a risk also in these patients. Reduction of PTS, there are three important things which has been shown in the literature. So stockings we have to give anyway to the patients. Anticoagulation we have to give anyway to the DVT patients. The question is thrombolysis, yes or no? Now in selected patients like this, patients who are younger, thrombus is less than 14 days old, patient has good functional status, no risk of bleeding, patient can afford, doctors know what to do, and the life expectancy is more than 1 year. So then CTT can be think about. So which is very, very important. But when you do the CTT, please, you should also be ready that there could be an underlying lesions which we found once we remove the clot, that you are able to treat them with either ballooning or an stent in the deep venous system. Now, how do you do the CTT? Means a drug to dissolve the clot. So there are two important things. One is an anticoagulation like warfarin, acetrom, Xareltos, Predexas, Apixaban, Clexane, Fondaparinol. All these are anticoagulants. So what they do is they will make your blood thin and will prevent the clot not to go further. And your clot will be dissolved by the body slowly and slowly. The thrombolysis is different. Thrombolysis is we use the drugs which will break the clot and dissolve the clots. So like streptokinase, urokinase, TPase, reticulase, so all the new drugs which are there. So why don't we use the drugs IV from here? So if you use the drug IV from here, you require a higher dose and higher risk of bleeding. So what are the drawbacks of thrombolysis means? We want to remove the clots, dissolve the clots, but the drawback is you can cause bleeding, and especially the bleeding in the brain, which is the most dangerous thing. And that is the major drawback of any thrombolysis procedure which we do in the body. And the moment you tell the patient that there is a 1 to 2% risk of intracerebral bleed, most of the patients will not sign the consent form. So that's the biggest drawback what we face in the clinical practice. So that's why we don't want to use systemic. So IV thrombolysis in peripheral DVTs is not very useful. So there was a systemic thrombolysis plus CDT versus CDT. There is no randomized trial, but we think that in CDT you use less doses and you get less bleeding. So what that means in catheter directed means you take the catheter directly into the clot, into the popliteal vein directly. So you will use less drug, of course, and so it will be better. So some people started thinking, why to use the drug only? Why don't we just suck up all the clots? So people started using pharmacomechanical combination, means you use the machines to suck up all the clots and use a very small dose of drug. So the risk of bleeding will be less and you remove the clots. Now people are getting more order. Why to use the drug even? Why we just only suck the clots and get out of it? So now people are working on the machines and the things that we don't have to use the thrombolysis at all, and we just suck up all the clots, okay? So this is the chart. We started with the systemic thrombolysis 40 years back, and we are here at the town where we just suck up the clots or use sucking machines along with a small amount of drug. So the risk of bleeding is less. So this is a machine which was very popularly used. In India it was used around 5 years back. We were the first to use in the country, and an angiojet device. And what that means is goes from the small sheath into the clot. We spray with a very high pressure TPA into the clot, wait for 20 minutes, the clot becomes very thin and lies, and then we suck up all the clots through a Venturi principle. So it was a very robust machine, very nice results we used to get, but the problems were setting up. We were using thrombolytic drugs. The cost was quite a lot and it was really expensive. And with the knowledge, the newer trials came in. The justification to do the thrombolysis became more and more difficult. And the patients have become more aware, so we have to explain the consent in too much detail now. And once you explain the consent in too much detail with the trials, the patients, they don't sign up the consents. So in 2009, we used to do a lot of thrombolysis and suctions, but in 2022, we are very, very selective, not more than 2 or 3 cases a month. So it has gone down. And of course, the anticoagulations has also improved in the last 10 years. So we got a much more stable. So young lady in 2011 we did this. She is from UK, came to Dharamshala for traveling. She got a DVT. She contacted the doctor in UK, and they found me on the internet, and we want a thrombolysis direct. Okay. So at that time we didn't had all these devices. So what we do is we drape the patient, we put the patients on prone, and we puncture the popliteal vein or short saphenous vein, ultrasound guided. We put in a sheath and we take an angiogram. So when we take a venogram, you see all the white color things you are seeing inside. These are clots in the veins. All these are clots, the white color thing. And there is no contrast going into the deep veins. So there is an IVC here, common iliac vein, white color with the clots. This is the contrast. And you see the vein is full of clots. So what we did, we just suck up the clots with a catheter. So we used to use big catheters, and we used to leave this area behind because this is blocked. So we will suck up all the catheter below, and we'll try not to go the catheters here because we don't want to push the clot up into the lungs here. And we were not using an IVC filters. So that's another area. When we do all this procedure, should we use a filter or not? So there is a randomized controlled trials and data collected. There is no randomized controlled trial, but there is the data collected from the studies, which has shown that putting in a filter does not make a difference. So in selected group of patients, we do put in a filter, and if the patient can afford, or we are very aggressive, otherwise routinely we are not using. So we suck up the clots here, and then we give a thrombolysis, and then we run the drug for 24 to 48 hours. So this was when 2011 I'm talking about. So you'll see the progression how we have made. So we sucked up all these clots from the veins, and we left the top 1 to 2 centimeter of the clot in the common iliac, because we don't want to push the catheter through that, and we run the drug through the catheter, and 48 hours, 24 hours, we take the picture, it's all gone. Because it was a fresh clot 2 days before, everything is, you put in a thrombolysis, and it really clears up, and there is no narrowing. And then to put the patients on 3 to 6 months of anticoagulation, and patient can go home. And if you see these patients 8 years later, 10 years later, it's amazing. You can't even differentiate, it's the DVT leg and the normal leg. It's impossible. And it is really nice. And you look into the venogram of this patient, it's all clear, and the contrast is flowing into the IVC. So it's very neat and clean. Another patient, at that time, again we punctured, we took a venogram, and look, lot of clots here into the vein, and you can see there are 2 veins here, and this is there, no contrast into the IVC. So it's a beautiful picture and beautiful case to learn. If you see a patient with a leg vein, and you think this patient has a DVT, and the patient's ultrasound is normal, please always do a D-dimer, okay? And if the D-dimer is normal, then you know patient does not have a DVT. You are relaxed. But if the D-dimer is high and your ultrasound is normal, so please repeat the Doppler again, maybe from a different radiologist. Because sometimes you miss, there are 2 veins, 2 popliteal veins, 2 SFVs can be there. And the duplication percentage is 25 to 30%. That's a huge number. So you could have 2 veins in the legs, and only 1 vein could be DVT, and the other vein, the Doppler, the radiologist can see and say it's normal. And he may not be that aware, because most of the radiologists are not trained for doing the scans in the legs. It is a drawback, what we can do. So anyway, so this patient, we did an angiogram, and you can see there is no contrast flowing down. And see the difference in the clot. See, what's the difference in that clot and this clot? Those clots were heavy, soft. And this patient had a chronic small clot. Can you see this fibrosis which is here? So this is an acute on chronic occlusion. And when you take the chronic history of this patient, you find that this patient had a chronic lesion. So when you took an angiogram, after this, and you see both the veins be cleared up with a thrombolysis. Can you see duplication? Common femoral vein, walls here, and no contrast flowing up, even after 24 hours of thrombolysis. So now you take the patient again, took a venogram here, and then you find lot of collaterals into the gyrus vein, internal iliac vein here, and the contrast is not flowing here. And the wire is also not going. So that means it's a chronic occlusion. So this we found in lot of thrombolysis patients. So finally we crossed the wire, we gently ballooned it with a very small balloon, 6 mm, and then slightly bigger balloon here, and then we place the stent over there, and then the contrast you can see, and see if we can flow, and it is still not flowing. So we had to put in the stent. So then we put in the stent, you can see, placed here, and the contrast is flowing. Now if you see this picture now, you can say this is a wrong stent, because I'm not happy with this stent. Because at that time, all the newer stents were not available with us. We had a very small stents available, the sizes were different. If I have to do this case now, so I'll put in a stent which is from here and it's going up to this point. So longer stents and bigger stents we will put in. Case 3, the last one, is the left upper limb. So you can get a clot in the deep veins here. You can see the upper limb here and central venous obstruction. You can see there is no contrast which is flowing. So this is the vein into the heart. So that's the heart here. And there is no contrast flowing into the thing. So patient has got the DVT here. So we used an angiojet device, which I showed you there. So that's an angiojet device. You can see it's a small thing over a wire, and it is spraying the drug into the clot, and then we suck up all the clots through the same machine. And it can give you a very nice final venogram, and without any major drugs usage, and you can get a very good clearance except a small narrowing over here. Then a new device which has been used in the last 4 to 5 years is an indigo device like this. It's called a Penumbra, is the name of the company. Basically it's just a simple suction device. Very, very simple device to use. Anybody can use it. Very cheap. Okay, the machine, the catheter, we reuse it. It's expensive, but we can reuse it. And if the patient cannot afford. So this is a very simple thing, acute DVT, we punctured the SSV here, and we took a venogram, put in a 9 French sheath. This is the name of the catheter. We give heparin in, and I'm not using any thrombolytics here at all. So I just sucked up all the clots. So you see, it takes like 7-8 passes, and most of the clots you can suck up, and you can see there are small clots here somewhere, but most of the veins has a good flow, and I put the patients on anticoagulation and no thrombolytics used. So another one example here, huge number of clots, catheter, suction, remove. So if the patient has only acute occlusions, soft clots, this catheter works very well. But if the patient had acute and chronic occlusions, then this catheter is not very good in our clinical experience. Then angiojet works much better. So another one, patient has this occlusion in the iliac veins here, put in this. So it's a small channel which we have created, but if you have to make in the flow, because this will block immediately, so then you need to put in the stents in this group of patients. Thank you.